Now let's talk about intrinsic hemolytic anemias. In intrinsic hemolytic anemias, we have hereditary spherocytosis. Hereditary spherocytosis means spherocytes formation, right? So let's talk about this. We have the primarily autosomal dominant thing, which is due to defect in protein interacting with RBC membrane, skeleton, and plasma membrane. So we have the RBC membrane, skeleton, and the plasma membrane proteins. What are they? They are the N-chirin, band 3, these are very important, N-chirin, band 3, and protein 4.2, and spectrin. What are these? These are proteins that interact with RBC membrane, skeleton, and the plasma membrane of RBC. Small round RBCs with no cellular central pallor, spherocyte, right? Decrease in surface area to surface area, dehydration. So when you decrease the surface area, how do you decrease the surface area? Okay, let's just draw this. So we have the cell, this is the normal RBC, right? And we have the tethering proteins that are here that bind to the cytoskeleton, and that makes up this whole disc-shaped cell. This is the cytoskeleton, okay? And this is the plasma membrane of RBC. So they're bound to the plasma membrane, okay? And to them, cytoskeleton binds and forms the proper disc shape or proper RBC shape cell. But if you lose these proteins, so that leads to just RBC, and the cytoskeleton cannot bind to anything, so it's just a round cell. But we still have normal hemoglobin levels here, right? So when we, from that big cell, we form the small cell and normal hemoglobin levels. That is to say, we have from this surface area, but now we have so small surface area, we have increase in MCHC concentration. That is important. We have increase in MCHC concentration, or increase in MCHC because of why? Because of that hemoglobin is now condensed in a small area, and that hemoglobin caused increase in MCHC. Okay, that's one thing. That now this cell leads to removal by the spleen, premature removal, because in the sinusoid this circular cell cannot go there. It's small, but it's circular type. It's a small round RBC. It's not going to go into the can't go into the sinusoids of spleen, leading to hemolysis leading to extravascular hemolysis because it's not occurring in the vessels. So let's look at the finding. We have the splenomegaly. This all is going to go into spleen. Spleen is going to go into megalies, leading to splenomegaly. Pigmented gallstones, that leads to lysis, increase in unconjugated bilirubin. That bilirubin is going to go into the gallbladder, goes out. So much is there that is going to cause gallstones, pigmented gallstones. Aplastic crisis. What was aplastic crisis? Remember, we just talked about that. It was that we will just have one line defect. That means we'll have anemia only. That is aplastic crisis. And remember, I talked about this also, that parvovirus B19 is sort of infection that you can just think about whenever you have some defect in the production of RBCs. If you already have a defect, you are prone to getting parvovirus B19 infection. Some more points on parvovirus B19 infection are it causes, as we said, it causes aplastic crisis in patients in underlying hemoglobin disorders, in any disorder, for example, sickle cell anemia or anything. in patients who need continuous RBC production. So any person, any patient who needs continuous RBC production, they are prone to getting the parvovirus B19 infection, and that virus, which is going to further mess up their thing and will cause aplastic crisis, which is anemia only, and symptomatic anemia, not just anemia but symptomatic anemia. And how does this B19? It doesn't have a magic. B19, what does it do? It inhibits the erythropoiesis. When you inhibit the erythropoiesis, you have anemia so much so that it's going to cause signs and symptoms. Okay, but what's the treatment for this thing? It's going to self-resolve. Okay, and treatment is just supportive. Okay, and what about the patients who are normal? Do they get parvovirus B19 infection? Well, if the patients who don't have any underlying disorder don't get affected as much, because they can get affected, but we will not see any anemia because we have the reservoir for the RBCs. But in case if you have some RBC defect, that means you don't have no reservoir. You need continuous RBC production, and this parvovirus inhibits that continuous RBC production, leading to anemia because you're inhibiting the continuous RBC production. But after some time, it's cell limited. It's going to go and they'll be able to produce the RBCs. Okay, yeah, and the bone marrow, if you were to look at the bone marrow biopsy, if you have a parvovirus B19 infection, you will see decrease, because it inhibits the erythropoiesis. You will see decrease in erythroid precursor cells, and giant pro-normoblast will be seen with glassy intranuclear viral inclusions. So giant pro-normoblast will have those glossy appearance of this virus inclusions, parvovirus viral inclusions intranuclearly. So yeah, that's pretty much what we have. But let's also talk about one more thing here. What else gives you just the aplastic crisis? Just the aplastic crisis, meaning anemia only. What else? So we talked about B19. What else? So thymoma, which is, again, you can see that on the CT scan of the chest, you will see enlargement of the thymus. That's the thymoma. Also associated with myasthenia gravis. Second thing is the lymphocytic leukemias. And the third thing was just the B19 infection. Okay. So let's move on with what we were reading. In labs, you have decrease in mean fluorescence of RBCs in eosin 5 melamide EMA binding test. Very importantly, you will have increased fragility in osmotic fragility test. So what's going to happen is RBC hemolysis with exposure to hypotonic solution. So you had a cell here. Now you have no cytoskeleton being holding the space of that RBC. You put this in hypotonic solution, the water is going to go into that RBC. It's going to swell. The cell will swell and eventually burst, leading to increased fragility in osmotic fragility test. Normal to low in MCV with abundance of RBCs. Treatment is splenectomy, because all of the hemolysis is by the spleen. So just take it out and you're good to go, because you can't do nothing about it. You just have an autosomal dominant disease. Take out the spleen, man. All right, that's all for the hereditary spherocytosis. Let's move on with the paroxysmal nocturnal hemoglobinuria. So here, what we have is hematopoietic stem cell mutation of stem cell. Which cells? Hematopoietic. Leads to increase. Just remember the name: paroxysmal, nocturnal, at night, hemoglobinuria. Heme is going to go into urine. Let's find how. So you have an increase in complement-mediated intravascular hemolysis. Who's causing the hemolysis? The complement, your own complement, especially at night. Why at night? And they're going to talk about why. If they're not, I'll talk about it. But acquired PIGA mutation, which leads to impaired GPI anchor synthesis for decay accelerating factor DAF and CD55. So normally, I don't know if they're talking about it. Actually, we protect against the RBC membrane from the complement. So here's the deal here. Simplified form. We have the RBC that contains a GPI on top of it, on the membrane. GPI. Okay, so that GPI now anchors two things. Now attached to these GPIs are two things. One thing is DAF, which is also CD50, known as also CD55, or MIRL, which is also known as CD59. They're attached with the GPIs. GPIs are attached to the plasma membrane on the RBCs. And what do? The only job of these two things is to inhibit C3 and inhibit the MAC formation, or to inhibit the complement system activation against the RBC membrane. So what are they doing? They're just inhibiting the complement activation against the RBC. In blood, we have RBCs and also the complements going, right? So their job is to let them know, hey, you can't get activated against us. Okay? But what if, let me change the color. What happens is here, you have impairment of this GPI. When you impair the GPI, your DAF and MIRL, they cannot bind. When they cannot bind, they cannot inhibit the complement system, which is normally they would be doing it, but they cannot do it because you don't have these two things. So the complement system activates against the RBC, destroys the RBC, leading to hemolysis. So let's read here now. Impaired GPI, which was normally anchoring the DAF and MIRL, which would protect the RBC membrane complement, but now the whole process is impaired. Okay, this whole process is impaired. When this is process impaired, you have a triad in which you have the Coombs negative hemolytic anemia, mainly intravascular. First thing. Second thing is pancytopenia. Third thing is the venous thrombosis. So guess what? You have hemolysis and complement formation. Guess what? You are going to have some thrombosis within the vessel as they're destroying the complement. They're destroying the RBC. Because remember, the complement doesn't just come and say, hey, I'm going to eat you. It has all the complement cascade and the MAC forms, and then you destroy the RBC. This whole thing makes a thrombus within the vessel. So here's the venous thrombosis. Example, Budd-Chiari syndrome. Leads to pink red urine in the morning. Why in the morning? Because it's occurring at night. So in the morning, you're like, whoa, that is some good color urine. I better see a doctor. associated with aplastic anemia and acute leukemias. In the labs, you will find CD 15, 55, 59 not present on the RBCs, on the flow cytometry. So CD59, 55, 59 are not going to be present on RBCs because they don't even have the GPI that was supposed to be there so that they can bind. So on flow cytometry, you have absence of that. Treatment is eculizumab, which targets the terminal competent protein, which is C5. Excuse me. This targets the complement protein C5 and inhibits the complement system. Okay. Now, clinically, you have this Budd-Chiari syndrome, right, as a complication. This is also the main cause of death in these patients. Budd-Chiari syndrome. Not Budd-Chiari, but venous thrombosis. So venous thrombosis is the main cause of death. Excuse me. But you're not just only getting Budd-Chiari syndrome. What you can also get is all the veins, like portal veins, hepatic veins, cerebral veins. Excuse me. And this one, you have an episodic pink red urine in the morning, episodic. And that's all for the paroxysmal nocturnal hemoglobinuria.